So I will be talking about consolidating primary in metastatic non-small cell lung cancer, who, when, and how. So I think this topic is quite deep because here we are not talking about giving palliative radiation therapy for pain, bleeding, airway obstruction, etc., which are all well-recognized indications of radiation therapy in metastatic situation. So the point that I'm trying to answer today, the issue that I'm addressing today is consolidating radiation therapy to primary disease, even in the setting of metastatic lung cancer, when majority of the patients are asymptomatic for the primary disease. So first of all, I would, like to ask this question: is this topic relevant? I think this topic is quite relevant because metastatic non-small cell lung cancer represents a big subset of patients. 50% of the patients who have non-small cell lung cancer have metastatic disease at presentation. And even patients who have locally advanced non-metastatic disease have predominant pattern of failure in terms of distant metastatic disease. So this forms a big subset. Additionally, if you look at the pattern of failure, even in patients who have metastatic lung cancers, this is a study which included approximately 400 patients who had metastatic lung cancer. And after first line of chemotherapy, they looked at their pattern of failure. And the predominant pattern of failure was persistence of the, say, metastasis or the local disease in the patients even after systemic therapy.
Dr. Vineeta, your slides are not moving.
Oh, is it?
Go to the second slide and then pick it.
Okay. So I had started from here that are they moving now?
No. We are not seeing the slide. We are just seeing the red line.
Okay. Is it visible now? I'll stop sharing and start sharing once again.
Yeah. Yeah, we can
Yes,
see.
ma'am. Now it's
Yeah.
We can see now, ma'am.
Okay, thank you so much. I'm sorry for this glitch. So I was saying that metastatic. So I'm talking basically about consolidating radiation therapy to primary disease in metastatic setting, even when the patients are asymptomatic for it. And the reason why this topic has probably been chosen by the organizers is because metastatic non-small cell lung cancer represents a big subset of patients. And even the pattern of failure studies have shown that even in the stage 4 disease, majority patients continue to fail wherever they start their disease from. For example, if there's a patient who's got carcinoma of left lung and with 3 metastases, even after chemotherapy, they continue to have local residual disease in those sites. They might get another metastasis, but those sites, they tend to persist. But let me also remind you that metastatic non-small cell lung cancer is not a single disease. It's a spectrum. Patients can have solitary metastasis, they can have oligometastasis, they can have polymetastasis. Metastasis may be synchronous or metachronous, and within that also they can have short or long disease-free interval. Even the primary disease can be N0 or N plus or T1 to T4 disease, and the driver mutations may be present or absent. So when I'm talking about metastatic non-small cell lung cancer and when you are talking about metastatic non-small cell lung cancer, we might be talking about a different spectrum here. Even within the oligometastatic disease, we know that it is again a spectrum. Patients can have synchronous disease, metachronous disease. They might have oligoprogression or oligopersistent disease. So there is a wide spectrum of disease within this also. Fortunately, AJCC 8th staging has also recognized that oligometastatic disease is a separate subset, and M0 disease and M1 has been further classified into M1B, into single extrathoracic metastasis versus M1C, which is multiple extrathoracic metastasis, reflecting that oncology community is gradually realizing that there is a paradigm shift in the management of metastatic disease, and we are moving away from the classical teaching that M1 means non-curable. Although the fallacy is that the biomarkers are yet to be incorporated in this staging system. So when we talk of oligometastasis, we all know that this was proposed by Hellman and Bischelbaum in 1995. And oligometastasis represents an intermediate state where there are a number of metastasis and destination organs are limited. We know that metastasis occurs in stepwise manner. Initially, there is limited disease followed by widespread disease. And we are trying to nip the disease when it is in the oligometastatic state so that we could offer cure to some of these patients. Unfortunately, we have high sensitivity images like PET-CT and MRI, which help us in identifying this oligometastatic state well. There is a lot of confusion about how to define oligometastatic disease. Majority studies have included up to 8 studies have included up to 8 metastases as oligometastasis, but majority studies restrict up to 5 metastases. EORTC lung group has defined that up to 5 metastases in up to 3 different organs are to be considered as oligometastasis. Here, mediastinal lymph nodes are not counted as metastatic disease. Astro and Istro think have proposed that 5 metastasis is fine, but what is important is the ability to deliver safe and clinically meaningful radiation to all metastatic sites as the definition of oligometastasis. So the present definition of oligometastasis is based on the numerical value and imaging, and the biology and genetics are still to be incorporated. And when we talk about giving radiation therapy to the local site in oligometastasis, we are trying to achieve a potential cure because we know by the pattern of failure studies that these patients ultimately, majority of them, they progress in these sites. And we are also trying to achieve immunomodulation and abscopal effect. So if I have to summarize my first 10 slides, the point that I'm trying to make is that let's not put all metastatic non-small cell lung cancer patients in one bracket. We must identify patients with oligometastasis with good biology. So going forward, I will take you through some studies which have shown the advantage of local consolidative radiation therapy. This was one benchmark study which came in 2016 from MD Anderson, which included stage 4 lung cancer patients with less than 3 metastases, up to 3 metastases. All kind of non-small cell lung cancer patients were included in this. All patients were treated with frontline up to 4 cycles of chemotherapy or EGFR or ALK inhibitors. And following that, they were randomized into either maintenance therapy versus observation or local consolidative radiation therapy or surgery with or without maintenance therapy. The type of local consolidation radiation therapy was decided by the MDT, but the trial had an early closure after accrual of about 49 patients because this interim analysis showed that the median PFS in the arm receiving local consolidative radiation therapy was almost 3 times of the arm getting only the maintenance therapy, 3.9 months versus 11.9 months. Now, the same study have published their results after a longer follow-up of approximately 3 years, 38.8 months. And now it shows that there is a definite PFS advantage, and also there is an overall survival advantage. Look at the overall survival advantage in the arm receiving local consolidative radiation therapy. It was 17 months versus 41.2 months. So this impressive overall local survival advantage was achieved even in the absence of immunotherapy without any major toxicities. Now this study, which I showed you just now from MD Anderson, included all comers. It had EGFR mutated as well as non-mutated lung cancer. There's another small study which excluded patients with EGFR and ALK mutation. Patients who had stage 4 lung cancer with limited metastasis were treated with 4 to 6 cycles of chemotherapy. Patients who had partial response or stable disease and up to 6 extracranial metastases were given consolidative radiation therapy with SPRT, and again, the similar outcome. This study also showed that the arm which was receiving patients who were receiving SPRT, apart from the maintenance chemotherapy, had a progression-free survival which was almost 3 times that of the arm not getting local consolidation radiation therapy. There's another interesting retrospective analysis from MD Anderson, which included large number of patients, close to 200 patients, up to 3 metastases, who were given standard of care systemic therapy plus local consolidative radiation therapy. This trial again showed that there was a PFS advantage in the patients who received local consolidative radiation therapy, but it also showed in subset analysis that patients who had squamous histology compared to adeno, patients who had higher T stage, higher N stage, or bony metastasis, they did worse than their counterparts. So there are several ongoing phase 3 trials which are currently accruing patients for this consolidation radiation therapy. So my second message to the audience at this point of time is that there are several phase 2 and retrospective data which have shown that there is a PFS and some have also shown OS advantage when local consolidative radiation therapy is added to primary as well as metastasis in metastatic non-small cell lung cancer, although we need to be careful in selecting our patients. Now let's come to another subset of metastatic non-small cell lung cancer, which is EGFR mutated carcinoma lung. We know that EGFR is one of the key drivers, and they have better outcome than non-mutated non-small cell lung cancer. And the standard treatment for the EGFR mutated lung cancer is EGFR TKI. But ultimately, majority patients will develop acquired resistance after 9 to 14 months of TKI therapy. And let's look at the role of local consolidative radiation therapy in EGFR mutated non-small cell lung cancer. So this is one study, which is a retrospective analysis again from MD Anderson. So patients who had EGFR mutated lung cancer, stage 4, were treated either with first-line TKI or first-line TKI plus local consolidative radiation therapy. And this included metastasis up to 3 in number. This study also showed that there was a significant PFS advantage when local radiation therapy was added to TKI. And in fact, you can see that the median overall survival is not yet reached. Now, somebody can say that this study had very small number of patients. There were only 12 patients who got local consolidative radiation therapy. So let me show you another study. This study comes from China, around 230 patients who were treated with either TKI alone or TKI plus local consolidative radiation therapy. And for local consolidative radiation therapy, they were given all mixed kind of radiation therapy with gamma knife, cyber knife, etc., etc. And this study also showed that the patients who got local consolidative radiation therapy had a better progression-free survival as well as overall survival with the addition of radiation therapy. This benefit was regardless of the type of mutation. This benefit in PFS and OS was regardless of the type of metastasis in bone, brain, or lung metastasis. So the point number 3, the message that I'm trying to give you is that patients who have metastatic non-small cell lung cancer with either EGFR or ALK mutations, they benefit with local consolidative radiation therapy irrespective of the type of mutation and organ of metastasis. Another situation that we often come across is oligoprogression, when majority of the metastases are controlled with the systemic therapy, but 1 or 2 metastases are progressing. So this is another study, old study. It started in 2012, where stage 4 lung cancer patients who had oligoprogression after platinum-based chemotherapy, irrespective of their EGFR status, were given local consolidation radiation therapy, and they reported a median PFS of 9.7 months and overall survival of 20.4 months when the local consolidation radiation therapy was added. There's another study.
These are 2 minutes left.
Okay, sir. So there's another study which looked at the patients who developed acquired resistance to EGFR TKI. And when radiation therapy was added, the patients would continue on the same EGFR TKI without progression for a long time. We all know that ultimately all patients with EGFR mutation develop T790M acquired mutation. And even on osimertinib, they develop this mutation and resistance. So this is a study which looked at the 14 patients who were on osimertinib progressing, and they were given local consolidative radiation therapy. The progression-free survival was way better in these patients, and they could continue osimertinib for a longer time. So another point that I'm trying to drive home is that patients who have TKI resistant and oligoprogression also benefit with local consolidative radiation therapy to primary as well as metastatic sites. We know that oligometastasis is a spectrum in itself. This IPT meta-analysis also helps us in categorizing our patients of oligometastasis into 3 categories. They found that the overall survival was best when the oligometastasis occurred in the metachronous setting. It was intermediate when there were synchronous metastases, but the patient had N0 disease, there were no mediastinal lymph nodes. And it was worse when the patient had synchronous metastasis with N1 to N2 disease. So we can use this kind of substratification in optimally selecting our patients. Immunotherapy is the new buzzword in the management of metastatic non-small cell lung cancer. And these are the result of Pembro-RT phase 2 trial, which have shown that patients who had oligometastatic disease, when they were given SBRT low dose, 8:3 fraction, they had almost doubling of their overall survival as compared to patients who were not given this radiation therapy. So now this has also been accepted and incorporated in a lot of guidelines. This is ESMO guideline, which says that stage 4 patients with 1 to 3 synchronous metastasis at diagnosis may experience long-term DFS following systemic therapy and local consolidative radiation therapy. They have also mentioned that stage 4 patients with limited metachronous metastasis may also be treated with radical local therapy. Patients with driver mutations with oligoprogression may also be treated with radical local treatment. So my last two concluding slide to answer the question, who are the candidates who benefit from consolidating primary in metastatic lung cancer? I will say patients who have good performance status with oligometastatic non-small cell lung cancer. Up to 5 metastases is what is accepted. But a word of caution, majority of studies have used only up to 3 metastasis patients. So maybe in a regular clinical setting, we can stick to up to 3 metastases. Patients who have driver mutations present, patients who have oligoprogression or EGFR L inhibitors. Another question is when to give this consolidative radiation therapy. Ideally, we have to give minimum 3 to 4 cycles of 3 to 4 months of systemic therapy before starting consolidating radiation therapy to look at the aggressiveness of the disease. And so far, studies have shown that it is safe to combine radiation therapy with targeted therapies concurrently with due caution. And how? We have various options like radiation therapy, surgery, RFA, and cryoablation. Radiation therapy has an edge over other techniques because it is non-invasive and it is a precise treatment. One can choose to use SBRT, hypofractionated RT, or conventionally fractionated RT, keeping in mind that we should be able to give radiation with adequate BED. Minimum BED required is 60 gray and preferable is up to 100. Thank you so much.